On behalf of the International Coronary Congress, I'd like to welcome you all to our 9th meeting. And more importantly, you are all part of the first Advances in Perioperative Care program, which is very exciting. Just a little brief history about the International Coronary Congress. About 11 years ago, Doctors David Taggart and John Puskas, after attending various international coronary meetings, realized that the focus on coronary surgery was decreasing. And the focus was going on valve surgery, aortic surgery, and so on and so forth. And as you can all remember, back in the day when the drug-eluting stent came out, they thought that we were going to go away. So everyone started decreasing their focus on coronary surgery. But thankfully, the science has proven them wrong, and we're still here, and we're growing, and we're doing some amazing things. So as we started talking about this program, we put together a team approach to the care of the coronary surgical patient. Because as we know, the patient only spends X number of hours in the operating room, but everything that's done before and all the hours and days and months thereafter is what really makes a massive impact on the care of that patient and their outcomes for the future. And that's all what you all do here. So that's why we decided to put together this team as a team approach to cardiac surgery, focusing on nursing, advanced practice providers, critical care medicine, and as we move forward, anesthesia as well. So then we had this brilliant idea, but how in the world are we going to do it? So we decided to contact some amazing leaders, and these are our course directors. One person I know many of you know intimately is Dr. Shauna Friedman, Dr. Natalia Girardi, and Zareen Parvez. In addition to that, they put together a tremendous faculty. And all of these presentations today are really going to enhance the team approach to the care of this patient and really look at how do we innovate and how do we make changes and improve things going forward. So I'd like to introduce Dr. Shauna Friedman right now. I can speak all morning about everything that she's done, from the educational programs that she's attended and really surpassed in, and all the programs that she covers within the Mount Sinai Health System. But she is the Executive Director of Nursing Operations and Cardiac Services at Mount Sinai Morningside, but more often than not, she's all over the system. And just to really condense it down, she's really been an amazing champion at putting together teams that advances the care of the patient, increasing outcomes, increasing efficiency, and with the end result of decreasing morbidity and mortality. So thank you.
Thank you, Rich. So good morning, everyone. It is a great pleasure and honor that we welcome you to the first inaugural Cardiac Surgery Nursing, Advanced Practice Provider, and Critical Care Conference. Today marks a significant milestone as we gather here to explore, discuss, and advance these pivotal roles in the realm of cardiac surgery. In the ever-evolving landscape of healthcare, cardiac surgery stands as a beacon of innovation and life-saving interventions. As nurses and advanced practice provider and critical care medicine doctors, we play a crucial role in ensuring the success of these procedures, providing compassionate care and promoting positive patient outcomes. This conference serves as a platform to enhance our collective knowledge, our shared experiences, and forge collaborations that will undoubtedly elevate the standard of cardiac surgery. Our journey today will take us through a comprehensive exploration of the latest advancement in cardiac surgery techniques, patient care protocols, and an interdisciplinary collaboration. In the spirit of collaboration, I encourage each one of you to actively engage in discussions, exchange of ideas, and foster connections that will extend beyond the confines of this conference. Together, we will shape the future of cardiac surgery. In conclusion, I extend my deepest gratitude to all the participants, speakers, and organizers who have contributed to make this event a reality. So, thank you, everyone. And to start us off, we will be hearing from Dan Carlos Almovar. I hope I didn't butcher that. I probably did. I just know him as Dan. He is our director of our advanced practice providers for our cardiac surgery team at the Mount Sinai Morningside campus. And today he's going to be going over what's the meaning of EKG changes after off-pump, EKG changes in post-operative CABG patients. Dan, the podium is yours.
Good morning. Wow, what an honor it is to kick this off. So I'll be going over EKG changes in post-operative CABG patients. Let's get started. Hold on one second. All right, so let's start with a little overview. We're going to do a couple different things here. First, we'll look at things in the operating room that at least may affect our EKG post-operatively. We'll do some examples of common EKG findings we may find in our ICU. We'll also look at some uncommon ones that may set up a little alarm in your head. We'll then look at assessing the patient. We'll look at then finding a workup that we're going to do to at least figure out what's actually going on with the patient. And last but not least, we'll then move forward with the plan. So let's get started. So the first thing, let's look at intraoperatively, what is happening that may cause EKG changes. The first is kind of something simple, right? We're manipulating the heart, right? We're touching it. And as much as I can talk about this, I think the most important thing is for people to actually visualize this. So you should be actually going to the operating room. And we encourage that in our program by at least having someone see a case or two. And I think that kind of solidifies everything that's happening in terms of what's occurring in the ICU. So that's, I think, a simple thing we can do. But that's just one of the things. Next is there may be ischemia from inadequate myocardial protection. Now that's something that more relates to the surgeon, but is a possibility. Not necessarily related to us in the ICU, but is a possibility. Next is air embolism, and that will definitely cause EKG changes, and that can carry into the ICU, but that should be something that eventually resolves. Next is pericardotomy, and that's essentially just something simple, right? Incision into the pericardium, getting to the coronaries, and that can cause some inflammation. You'll see changes in your EKG due to that. Next is direct cardioversion, and that essentially is for our on-pump cases that need, essentially you're going to restart the heart, and sometimes it doesn't come back into normal sinus rhythm, right? You may be in AFib, you may in VFib, so we're going to shock them using paddles, and we'll apply electrical charge, just like we do on the outside of the body, we do inside. So we'll apply a small electrical charge, get it back hopefully in normal sinus rhythm, and off they go. Sometimes this may happen multiple times, but hopefully it's just once. And then last but not least is myocardial stunning. Now there are other factors that may come into play here, but I'm just going over these few. I think this one is more important for us, at least at MSM, because we are doing a lot of off-pump surgery. So there's two forms, on-pump and off-pump. Dr. Puskis does most of his cases off-pump. So it's a little different, and I think this is where going to the OR kind of solidifies what you see. So if you have the chance, watch one on pump, compare it to the one off pump, and you'll see that in terms of heart manipulation, possible ischemic times actually while you're working on a beating heart, I think it kind of solidifies all the things that you see in the post-op care in the ICU. And that a lot of time will be reflected in your EKG. So kind of moving forward, let's do some examples here. So here's our first EKG. I don't know if anybody wants to give it a shot in terms of what they see. Anybody? Anybody? Well, let's go ahead. So first, let me put on my glasses to make sure I remember what I'm seeing. But we kind of have some diffuse ST elevations throughout the EKG, if you kind of take a look. All right? So pretty much in all leads, we have some ST elevations. This would be kind of consistent with pericarditis. All right, is this something that we're incredibly worried about? Not necessarily. Simple things like bringing it to the attention of the surgeon. In instances like these, many times it resolves by the time they're discharged, but for those who actually want to treat it, simple things like NSAIDs, they'll use colchicine for patients, but that's in just some cases. So this is one of the common findings you may find. The next, over here, I don't know if anybody wants to give it a shot. Let's see. No victims, okay. But we're looking at basically a right bundle branch block, okay? We're looking at the RSR pattern in V1, V2. We'll see some changes in V6 also, some QRS widening. So in this, the literature at least is very kind of vague in terms of how often we'll see this. It ranges essentially from 5% to 50%, which I think is a lot. If I were to guess in our own institutions, probably closer to 10. And even with that, most of the cases are patients who had right bundles coming in. So for the most part, at least the ones that we see post-operatively, they've essentially resolved by the time they're discharged. So we'll look at the next one. Next one, we have a little something a little more sinister here with we'll see some ST elevations anteriorly, septally. It looks like they might carry off to the lateral. So this is something, at least when assessing your patient, you should be kind of keenly aware of, that this is just something not to ignore, but at least to follow. And we'll talk a little bit more about the things we'll do to monitor these cases. But this is just one. Let's go to the next. This one's, I tried to find one that was a little more obvious. You'll see some ST depressions, same thing, anterior, extending laterally. So these are the things at least you should be looking at that should kind of set off an alarm, and you've got to keep on, working up the patient. So let's start with assessing a post-op patient, all right? Simple things like taking good sign out from both anesthesia, and if you're lucky enough to have a resident or a fellow, you might be able to have them actually provide you with some information from the operating room. And you should ask at least relevant questions related to what you're seeing on your EKG. Obviously, examining the patient, I think, is important. Going through their drips is what they're on, abnormal, normal for what you're seeing for your typical CABG patient. Chest tube output, are they patent? Is there a significant amount of chest tube output? Mechanical support, more or less, I think, ECMO is obviously something went wrong. But if you're talking about a balloon pump, inserting one preoperatively as opposed to intraoperatively, I think presents you with an entirely different patient. So that should be an area of concern if that happens. Pacing, right? What was the patient going into the OR? Were they just bradycardic? Did they actually lose their rhythm? And then basically after that, if you still have concerns, I think the most important thing is to talk to this guy, all right? And that's the surgeon. That's the typical view when you're telling them, hey, I think there's an issue with your patient. But yeah, but nobody knows the patient better than the surgeon. And you at least communicating with them, I think, is kind of one of the fundamental things we need to do as providers, all of us. And communicating with surgeons can sometimes be difficult depending on the person. Other times it's a little simple. But the other thing is, especially in our institution, they're usually pretty busy. And they are likely not hanging around the ICU. They're usually likely in the OR. And so it's your job to kind of go and communicate this to them. So you may have to get dressed up in the little bunny suit, go in there and speak to them and look at you, hey, what are you doing here? That's, and you've got to actually communicate with what's going on, right? They're the ones that knows the patient. They know what went on. There's been plenty of times where I've been in the ICU, things have happened in the OR, and I wasn't told, but hey, they knew. They may say, hey, it's not that big of a deal, just keep on monitoring, or there may be something more going on in which they want more information. So I think communication is a big thing. And I think about that a little bit there's a kind of fun show called Air Disasters that I love to watch. And essentially it deals with, airline accidents that they send a team of investigators. They actually wind up investigating what happened. Half the time it's actually human error, right? But many times, believe it or not, it's actually communication between the pilot and the co-pilot. And so sometimes there's an issue where there's some friction between the two and there's a lack of communication. And because of that, essentially leads to the demise of the patients and the passengers, right? And so that's the way I kind of view our role as providers here, is like my job is to prevent something from happening to this patient. And so I have to go and actually seek it out. I can't expect, little things like he's unhappy to get in the way of the patient care, right? So you've got to go out and actually speak to the surgeon, and then once you've given him the information, you can kind of proceed forward. So let's move forward. So typical things for workup, obviously we'll continue doing serial EKGs, all right? We'll do echo, and when I talk about echo, it's not just the little POCUS, the little bedside, like a real echo from a tech, a cardiology fellow, or if you're lucky enough, maybe a TEE while you're in the ICU. Serial cardiac enzymes entailing troponins, usually CKMBs, and then you can trend all labs, simple chest x-rays, right? Looking for effusions, widened mediastinum, and then you'll continue to assess pressure and inotrope requirements. And that will let you know kind of what direction it is, but you're hopefully stable. So in kind of moving forward, right? So if we're doing this workup, right, and we find some new wall motion abnormalities, that's definitely significant, right? When we're looking at troponins, for most of us, people get labs and they're like, well, I don't know, it looks kind of high, maybe. But when we're looking at the troponins that we're drawing, at least when the levels have reached essentially 10 times the kind of 99th percentile of the high margin, those are reasons to be concerned, at least lab-wise. For us, once it's rare at least we have MIs post-operatively, but once we start getting troponins that are elevated, that should set us off. There's lots of risks involved, including, greater ICU stays, risk of MI, MACE events. These are all things that definitely affect our outcomes, most importantly, because we're a CABG center. But I think it's important that this, of course, be relayed to the surgeon. Now, in terms of what we're looking at in the future, we have now, at least in our hospital, the high sensitivity troponins. So when we start talking about troponins of 30 or a little higher, that is not necessarily significant. That's actually pretty normal. The new literature is essentially studying the high sensitivity troponin in terms of what are the levels that we're going to be concerned about. And the standard practice is now different because the new research within 22 to 23 this year has shown that usually about levels of about 500, that's where you start becoming concerned, and they can go much, much higher. Now, in those cases, they were studying all cardiac surgery together. So we're looking at valve cases, CABG cases, aortic cases. And I think in the future, you're going to have that totally defined as when to be concerned. But that's definitely a change from what we were using before, because in the our old troponins, if you had a troponin of 30, that was definitely something that was significant. So just be mindful of that. This is the official definition of what we've now just spoken about, right? If you've got that elevated troponin of 10 times baseline, we've got a type 5 MI. You don't find that very commonly. We're used to the other MIs, 1 and 2, but yes, it goes to type 5, and this one is specific for CABG. And there's also the definition, which kind of goes into new Q waves and left bundles. I think that's a little obvious on your EKG if you happen to see that. So what are we going to do about it? All right, that's the main thing. This should be definitely discussed with the surgeon. Do we go back to the operating room? Or do we need to maybe speak to an interventional cardiologist, go back to the cath lab, do an angiogram, but that's usually very specific in terms of who the surgeon chooses to actually do the angiogram. So that needs to be a discussion. Or are we just going to sit and watch and hopefully this resolves and we stabilize and we see no other significant changes in the EKG? But, something hopefully you can see is something as simple as an EKG can lead you to kind of really evaluate what's going on with the patient and hopefully have a great outcome. But if not, you'll have at least an idea of how to proceed and hopefully get answers in terms of what's going on. Thank you so much. I appreciate it. Any questions?
Dan, that was a wonderful review, and I really enjoy going to conferences because every time I go, I learn something new or something that I might have known years ago, and it comes back. But looking at the EKG changes and did a patient have a post-procedural MI, when we look at these studies that are being published, the devil's in the details of looking at what's their definition of an MI. Is it 3 times increase in troponin, 5 times, 10 times? Some of these studies really put their own definitions in. So really have to take a nice hard look at that to make a decision on, well, is this study going to impact my practice?
Yeah.
Because the decisions are...
Yeah, no, absolutely. No, I think especially when you're looking at, things like troponin and stuff like that, I think that's one of the most confusing things, where most people kind of look at it and decide, well, it always seems to be borderline. That's what it always seems. So I was like, what do we do? This or that. And I think this gives you at least a better idea of kind of how to move forward. But it never seems to be straightforward when you're actually in the midst of it.
Well, as you said, it's all about communication, having that rapport and being able. Thank you.
All right. Thanks. Thanks, everybody.
Our next presenters are Dr. Peggy O'Malley and Sitora Mirasotova. Both are our nurse practitioners in our cardiac surgery step-down, and today they're going to be presenting depression and cardiac surgery. So, welcome.
Thanks. Good morning. Depression associated with cardiac surgery. Coronary artery disease is the leading cause of death and disability among men and women of all ethnic groups. In the United States, over 900,000 procedures are performed yearly, and it is projected by 2029 that there will be 1.3 million procedures done yearly. 26% of all deaths in the United States can be attributed to coronary artery disease, costing in excess of $10 billion a year. Fear and anxiety prior to cardiac surgery is predictive of postoperative complications such as depression. Sorry. Depression is not a bad attitude. It's not just being pessimistic. It is not just a time of feeling sad or moody. It is more than a momentary period of depression, of distress. Fauser and Smith compares depression to grief. It is a sense of loss, sadness, and withdrawal from usual activities. Depression is not just observed in the postoperative period. It is estimated that up to 47% of patients awaiting heart surgery are depressed. Healthcare providers, namely NPs, need to screen patients for depression throughout this process. Health-related quality of life is a benchmark. It's an outcome measure. It's self-reported and can include negative and positive affect. Pre- and post-op depressive symptoms are associated with poorer quality of life outcomes up to 6 months to a year after having heart surgery. 1/2 of CABG patients report mood disturbances. 19 to 61% of patients with cardiac disease have depression. Depression in patients with coronary artery disease are 3 to 4 times more common than in the general population. Depression following heart surgery is debilitating. It is underrecognized and undertreated. Diagnosis is also complicated by the medical condition. Symptoms may be psychological as well as having physical complaints. It is important to identify those who are at greatest risk of developing depression. Psychological factors can impact the progression of coronary artery disease, post-MI recovery, and post-operative recovery. People who are depressed have a decreased quality of life, decreased social functioning, increased disabilities, increased risk of developing chronic diseases, and a predictor of mortality and morbidity. Depression prolongs hospitalizations, slower postoperative recovery, poor adherence to treatment, including medications, and they are slower to regain their normal lives. Depression and anxiety may coexist. When there is significant distress, it may interfere with personal functioning, and it's a natural reaction to stress. Mixed anxiety symptoms include worrying, sleep disturbances, nervous tension, fatigue, depressed mood, loss of interest in life, decreased energy, and somatic symptoms. The impact of depression on myocardial infarction is threefold risk of cardiac mortality. With stable angina, 69% have a greater risk of cardiac death. Following CABG, there's a 2 to 3-fold risk of death, and heart failure, those patients have worsening outcomes. The screening tool for depression is the PHQ-2, which can have a maximum score of 6. The PHQ-9 has a maximum score of 27. And the PHQ-2 is good because it measures depressive symptoms over time. This is an example of the PHQ-2 and the PHQ-9. PHQ-2 is basically the first two questions of the PHQ-9. Why do people develop postoperative depression? It may not just be from the actual procedure. It may be related to a component of poor health, lack of control, poor social support, low socioeconomic status, and educational level. Factors that influence post-op depression are social support. Social support doesn't necessarily have to just mean family. It can be friends. It can be people in their religious circle. Religion plays an important role, and it doesn't have to be organized religion. It's what the patient feels is what they believe to be religion. Prayer, socioeconomic status, education, gender, and fatalism. Fatalism is a perceived lack of internal control over external events, in this instance, cardiac surgery. The idea that fate, luck, destiny, and predetermination play a role in disease, powerlessness to react to a health condition. Scholars believe that fatalism to be a trait in the individual. It's important to identify those who are at great risk of developing depression. Those at risk are females, individuals who are widowed and separated, individuals who did not finish college, those who don't pray, low socioeconomic status, and those who are diabetics. Depression is associated with how well the patient copes with stress. And looking at Lazaris and Folkman's transactional model of stress and coping. So the situation and event is cardiac surgery. The patient appraises this and they look at it. If they don't find cardiac surgery to be a threat, I haven't met any of those, they have no stress. But when the patient looks at this as a threat, and if they perceive that they have good coping skills, then they have positive stress. Those who don't have the ability to cope will develop negative stress, which leads to depression. Emotions play an important role. Negative emotions, anger, anxiety, they lead to depression and are key factors leading to cardiac risk. They lead to distress and irritability. Patients need to develop good coping strategies to have positive stress to decrease the incidence of depression. Protection against depression is spirituality and religion, hope, and identifying other forms of social support. Here at Mount Sinai Morningside, we spend a lot of time on our discharge, and we provide them with the opportunity to contact us frequently. We give them the number for the floor that they left because we're the last to see them. They have the office, and they're given the phone number that they can contact us 24 hours a day, 7 days a week. We live in New York, we're in New York City, and there are many lonely people that don't have social support, and this adds to their social support. Treatment options are pharmacological, which Satora will talk about, psychotherapy, and mindfulness training, which is bringing awareness to an experience. It is about well-being. We've developed a relaxation technique that is on the intranet, and it has auditory, visual, and it's a sense of relaxation with tensing muscles and releasing them and taking deep breaths. We're working now with Marcy to try and make it more available to patients. Not everyone has a computer. We've done it on a flash drive, but everybody doesn't have a computer at home, so we're trying to either get it on YouTube. Everybody seems to always have a phone, so we're trying to do that so that they can use this relaxation technique even prior to surgery and after surgery. The clinical implications of depression are that depression is a common problem following heart surgery. The financial implications are significant. If 25% of the patients that are operated on are readmitted within 30 days, this will impact reimbursement. But on a human level, patients are not interacting with their environment in a positive way, and they are not experiencing an improved quality of life. The WHO, in 1948, gave a definition of health. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. The goal is to develop positive coping skills that may include medication, relaxation techniques, or assisting the individual in identifying additional support systems that have been able to identify with and achieve their optimum level of health. In conclusion, the correlation between depression and subsequent coronary events has increased the awareness of the need to identify those who are depressed and go on to develop postoperative depression. Satora will now address the medications.
Hi, good morning. My name is Satora Mirsatova. I'm a nurse practitioner specializing in acute care and psychiatry. And today I'm here to talk to you about pharmacological treatments for unipolar depression. My goal today is to help you identify depression, talk to you about some of the first-line treatment for depression, and also increase your comfort level of taking care of patients with depression post-op without getting a psych consult. So depression and heart diseases have a reciprocal relationship. Untreated depression can worsen the heart disease, similarly as heart disease that's not treated can worsen depression. Depression can be a syndrome, like in major depressive disorder, or it can be a symptom that can be caused either by a medical condition, hypothyroidism, stroke, or MS. It could be caused by medications or substances. Medication Accutane that's sometimes used in adolescents for acne can also cause depression. Or it could be due to a recent stressor, such as a heart attack or hospitalization or surgery, which we often call adjustment disorder with depressed mood. DSM-5 identifies major depressive disorder as having 5 or more depressive symptoms within a 2-week period, and which represents significant change from their baseline. And one of the symptoms should be either depressed mood or lack of interest. And as we can see, these depressive symptoms actually negatively affect our patients postoperatively and can impede their progress. Depressed mood can cause self-medications. Patients sometimes can self-medicate on opioid painkillers or alcohol or other substances. Lack of interest can prevent them from walking, using incentive spirometry, or maybe showering. That can cause worsening edema, pleural effusions, or can cause surgical site infections. Poor appetite or overeating, malnutrition, increased sugar levels in our diabetics can cause or lead to poor wound healing. Sometimes insomnia or hypersomnia can cause them to skip the medications in the morning, for instance. Agitation could cause hypertension or tachycardia, and tachycardia is something that we always chase post-op and try to fix with our patients. Fatigue will prevent them from participating in PT or OT. In lack of concentration can be the reason why they're missing up the follow-up appointments or are not paying attention to our discharge instructions. And suicidal ideation can increase the risk for post-op mortality. So treating depression postoperatively is very, very important. Some of the first-line medication treatments or medication options for depression or unipolar depression, because it could be the bipolar, but I'm talking about unipolar depression, are SSRIs and SNRIs. And some of the common side effects of all antidepressants include suicide risk in adolescents or younger adults, which is transient side effect. Sexual dysfunction can cause mania and bipolar disease. If you stop them abruptly, some of the short half-life medications can cause withdrawal side effects. Hyponatremia and SIDH is something to watch for, and especially in older folks or people with heart diseases, renal disease, heart failure, patients on diuretics, which represent majority of our patients in cardiac surgery. Most of the antidepressants also prolong QTC, have risk for bleeding, and serotonin toxicity. So serotonin toxicity is also previously known as serotonin syndrome. It's a drug-drug interaction, happens rare, but it associated or occurs when a drug with potent MAOI properties is used alongside with another serotonergic drug. Can develop rapidly and can cause death within 24 hours. One of the drugs that we sometimes use in cardiac surgery is methylene blue. Actually has potent MAOI properties, and therefore, if we're planning to use it, we have to wait for a complete washout of their SSRI or SNRI preoperatively, and therefore it's important for us to get a detailed history preoperatively, MedRec, and take these things into considerations. Some of the symptoms of serotonin toxicity are rigidity or clonus, myoclonus, altered mental status, hemodynamic instability, high pressures, high fevers, tachycardia. So when we choose the antidepressant for our cardiac patients, it's important to see if the medication affects cardiac conduction, heart rate, blood pressure, whether it has drug-drug interactions, or can cause any cardiac risk factors such as weight gain, hyperlipidemia. The drug-drug interaction that is associated with most antidepressant is related to their property of inhibiting CYP2D6 enzyme. And many drugs, the levels of the drugs that are actually metabolized by this enzyme can be increased if we use them in combination with SSRIs or SNRIs. So the meds that we use commonly in cardiac surgery are beta blockers. Some of the beta blockers are, their levels can be increased when we use them with SSRIs or SNRIs. It can increase levels of warfarin or DOACs, causing risk for bleeding. Or it can cause, it actually can decrease efficacy of Plavix. And we often meet Plavix non-responders in cardiac surgery. So the enzyme CYP2D6 converts prodrug Plavix into an active drug. So if you have a medication that's actually inhibiting that enzyme, then the Plavix won't be effective. SSRIs work by blocking serotonin transporters and increasing serotonin levels. There are currently 6 FDA-approved SSRIs on the market. In 2012, FDA had issued a warning advising us not to use citalopram in a doses higher than 40 milligrams due to QTC prolongation, and in cases where we have a risk for increased levels of citalopram, such as in older adults, patients taking medications that inhibit 2C19, which are protonics or PPIs that we sometimes use, or patients with hepatic impairments, their doses should be maxed at 20. Citalopram can increase plasma levels of some beta blockers, causing the risk for bradycardia. Escitalopram, brand trade name Lexapro, can also cause risk for QTC, but it's not as much as citalopram. It's only with higher doses, 30 milligrams. It's usually a safe drug to use in cardiac patients, well tolerated. There are few drug-drug interactions. Sometimes tramadol can increase the risk for seizures. Fluoxetine, trade name Prozac. There's also similar FDA warning for QTC prolongation, and it has a very long half-life. So if your patient is on fluoxetine and you are planning to use MAOIs, you have to wait for 5 weeks for it to wash out from the system. Sertraline is actually a very safe drug option for our patients. It's proven to be safe for patients. There was a study done, a large RCT done by Glassman and colleagues that showed that sertraline was safe in patients with recent MI or unstable angina and had no effect on ejection fraction, PVCs or QTC prolongation. Just something to know that it might increase the levels of some of the statins. It's safe with pravastatin and fluvastatin. Paroxetine safer, but has withdrawal effects. I wouldn't go with this drug primarily. SNRIs, they work by inhibiting norepinephrine transporters by increasing norepinephrine, serotonin, and dopamine, and that feature actually can cause tachycardia and hypertension in our patients. So not something that we would go first choice. So one of the medications is venlafaxine, trade name Effexor. QTC prolongation, hypertension, tachycardia, not a first drug. To choose for withdrawal effects, adherence is important. Some patients actually had described as having a brain zaps if they would miss a dose. Cymbalta, no QTC prolongation. Although there's an increase in blood pressure and heart rate, it does not cause any sustained hypertension, so can be used, should not be used in patients with renal failure or hepatic impairment. And fun fact, it actually is approved in some of the countries for stress urinary incontinence. Not here, but we sometimes use it for chronic neuropathic pain. So don't stop them abruptly. If you have to stop it preoperatively, taper it down to avoid withdrawal symptoms. You can do it by dropping the rate by dropping the dose by 50% for 3 days, and followed by another 50% decrease for another 3 days, and then you can stop it. If patients start having withdrawal symptoms, then raise the dose until they stop the symptoms, and then start over at a slower rate. One of the novel treatment for depression, esketamine or Spravato, it's a nasal spray, now FDA approved for treatment-resistant depression or depression with suicidal ideation, has not been studied in cardiac patients, can increase the blood pressure, and the contraindications are history of intracranial hemorrhage or history of aneurysmal vascular disease. So that concludes, so in conclusion, if your patients are not progressing after the surgery, I urge you to screen them for depression, because depression could be a cause of some of the post-op complications that they're having. Either start the medication or resume their treatment, and then refer them to see a mental health provider. Thank you so much.
Thank you, guys. That was amazing. Didn't realize there was all those drugs and how they affect cardiac. So our next speaker is Dr. Michaela Yemen. She is the assistant professor of the Icahn School of Medicine. She is also the director of our cardiac surgery ICU at Mount Sinai Morningside. And today she's going to be going over how do we manage common complications after cardiac surgery, lessons learned.
Thank you. I'm gonna start my timer because I'm gonna try to jam in a lot of topics within 20 minutes, so wish me luck. So I think, in my opinion, some of the common complications we see immediately after surgery are bleeding, which is going to take a bulk of this talk, arrhythmia, shock states, and the one that we fear the most is neurologic complications. So I want to go over how we manage this, and this is really based on my experience working at 4 different cardiac surgery programs in the New York area. And what I have learned is everybody does it differently. Unfortunately for us, it always works. So sometimes you kind of have to go with it when you go to a new institution and kind of learn from the process at that institution. I figured it's better to go through some clinical vignettes just to make it a little bit more interesting. Please forgive me, this is a valve case, not a CABG case. I know this is a CABG conference, but this is a case we recently had at our institution. I think it kind of puts in some of the points that I wanted to stress in terms of bleeding management. So this is a 76-year-old with limited English proficiency who came to us with chronic history of rheumatic heart disease. She's being admitted for a same-day valve surgery. She also, obviously, like most other patients, has atrial fibrillation. She's on Eliquis as an outpatient. When we routinely examine our patients in the preoperative holding area, when she was asked when her last dose of Eliquis was, she was kind of unclear when she took it last. So the question you face is, what do you do? Do you take her to the operating room or do you delay your surgery? So what we did here is we routinely use viscoelastic testing in our ICU, and she was kind of sure she probably took it 2 days ago. So the recommended holding period for most DOACs and NOACs is actually 48 hours. So we were feeling comfortable taking her to the operating room. Her case was relatively straightforward. She did have a long pump run of greater than 162 minutes. That in itself, you'll see, is a big risk factor for bleeding. Anything more than 120 minutes on pump increases your risk for complications for many things, bleeding being one of them. She also received about 1 liter of cell saver. Routinely in our operating room, our anesthesiologists check viscoelastic testing a lot. The times that they routinely check it is at the time of rewarming and right before leaving the room. So at rewarming, there was some coagulopathy, which they corrected by giving her some blood products. At the end of the case, right before leaving, or as they're packaging her, they started to do another ROTEM, which normalized, so everybody was feeling comfortable. In terms of her operative course, the only thing that was noted to us was maybe there was some concern from bleeding from the chest wall. What the surgeons felt was very well controlled by just using some hemostatic agents like vancomycin paste and bioglue. So they felt confident that this patient is not bleeding, so they brought her to the ICU. So everybody should have their own process of documenting, and nowadays all of our documentation is in the computer, so sometimes that makes it challenging in terms of communicating. So what we've adopted in our ICU is the nursing staff and all of our staff documents our chest tube output on the glass door that we have in the ICU, which makes communication quite efficient. So you could just take a look at it and know if there is a problem or not. So this is what you see there. Hopefully it shows. The case came out late at night, and we document for the first hour. Our process is to document chest tube output every 15 minutes, just to make sure we don't miss anything. And as you see, she arrived, 15 minutes was okay, and then after that, we had a lot of oh crap moments. And she bled quite a bit for the next 30 minutes. And then our labs, when they trickled in, always take time to return your labs. Everything is red. Red equals bad. So she was anemic, thrombocytopenic, her INR was elevated, her PTT was elevated. So she had a lot of coagulopathy that we needed to correct quickly. Our point of care ABG had already shown us she was anemic, so we'd already started to transfuse her before our labs came in anyway. So how do you manage bleeding after surgery? And that's the big question. I think the one part that I want to stress is bleeding management actually starts in the preoperative phase. You really have to understand the surgery the patient is going to go under, and you have to try to correct correctable problems before they start, like addressing medications, addressing underlying medical conditions like liver and kidney disease, and then things that we forget, herbals play a lot of factor in terms of bleeding. So understanding where the patient is coming from in terms of their language barrier, were they able to follow your preoperative instructions. So all of that needs to be caught on in the preoperative phase. Clot formation, there's two integral things in clot formation. One is platelet and the other one is fibrinogen. So those are the two things you want to optimize for your patients as best as possible. And that really starts, like we said, in the preoperative phase, knowing where they're coming from and what needs to be corrected. And one thing that we underestimate quite a bit is the role of anemia in terms of bleeding. I think anemia is not only a marker of poor outcome in our cardiac surgery patients, but it's an independent risk factor for bleeding. So hopefully we've all are starting to adapt ERAS protocol in our cardiac surgery programs, but this is something that we have control of in the preoperative phase. So all of our patients should be receiving IV iron, ideally, and EPO before surgery, whether they are or are not anemic, because they will be anemic after cardiac surgery. So we should really optimize their anemia in the preoperative phase. The second step to that is understanding medications. All CABG programs nowadays deal with P2Y12 agents because patients are being referred to as more of like a salvage because their stents didn't work rather than as a first-line treatment. So having a protocolized management of your P2Y12 assay, and you would think this would be something that's standard, but having worked through different institutions, it's very institution dependent, right? Some people are afraid of these medications, some people are not. So you really have to understand where your institution lies. What I would say is if you have a P2Y12 assay available to you, to use it to help you guide the timing of surgery, but don't stick to that as well because I think sometimes that prolongs the surgery and patients end up being in the hospital longer than anticipated in the preoperative period, and that in itself can be harmful to them. What to do about anticoagulants is another important thing that should be standardized. Most patients now are on NOACs and DOACs. I would say the only thing relevant to say about this point is to stop them early if you can and to bridge them with something else whenever possible. If you have availability of a 10A level, to check it routinely. And then if just in case of emergencies, having an idea of what's available in terms of reversal agents. And the DOACs now actually have reversal agents available, so you can always give them ahead of time if necessary. The two P2Y12 agents that we commonly encounter, at least here in our institution, is Plavix and Brilinta. The difference between the two we don't really pay attention to is Plavix is an irreversible P2Y12 agent. So you gave it, it's there, it lasts for the length of the platelet's life. Unlike ticagrelor, which is actually reversible, and recently there's a new monoclonal antibody that's become available as a reversal agent for Brilinta, which we haven't really seen that much. I don't know if anybody has experience using it. It doesn't seem very appealing to our surgical population because you have to infuse it for a long period of time, but there is a reversal agent that's coming, and hopefully we'll get some experience using that medicine soon. The next part is what happens in the operating room. So obviously you need to have, or in an ideal situation, you need a nice, meticulous, clean surgery. And the surgical technique of your surgeon, but also your anesthesia team, plays a good role in your bleeding management in the post-operative period. Cardiopulmonary bypass, if you do your CABGs on pump, plays a big role in bleeding risk. Obviously, the length of time spent on pump is a risk factor. Like I mentioned before, the longer you're on pump, the higher risk of complications that you'll see. The act of putting in, Rich probably will tell us this better, but the act of putting somebody on pump requires a lot of things like hemodilution, heparinization, and just the fact that your blood is coming in contact with the foreign material in itself causes a lot of activation of clotting factors, but also breakdown of clotting. So there's a balance between clotting and bleeding that you have to deal with whenever patients are on pumps. So you have to be able to deal with that, and some of the things that we do is reversal of heparin at the end of the case and giving medications like antifibrinolytics. The other thing to remember is heparin in itself is is a factor, because even if you reverse it, heparin causes platelet dysfunction that you can never reverse completely. So exposing patients to heparin, which happens on or off pump cabbage. So you can't, even if you say, okay, we're doing an off pump cabbage patients still have to get heparin for the majority of their case. So the heparin in itself is a risk factor. Most institutions now give Cell Saver back to their patients, which helps us manage anemia, but Cell Saver, I think, is a good indicator of many things. One is, if you have a lot of Cell Saver, that's usually an indication the patient lost a lot of blood. So those patients you have to keep a close eye on. The other fact is it may have some heparin in it because it's gathered while the patient is still heparinized. So if you're giving it at the end of the case, you may be giving them some heparin back, which you may need to catch up on. And then lastly, it's washed red blood cells. So especially when you have patients that undergo on-pump cases, they're already dilute because you've diluted them to support them with the extracorporeal support, and you're giving them red blood cells, which is going to further dilute their clotting factors and may impact clotting. How am I doing? 9 minutes, okay. Other things I think we kind of mentioned, viscoelastic testing has actually been quite helpful in bleeding management. It can be a little bit tricky, especially when you have an abnormal ROTEM or TAG, whatever you use in your institution. But if you don't have bleeding at the end of the case, or your suspicion for bleeding is low, do you just go ahead and correct or give products? And that's usually the question that we commonly deal with. What we have done in our institution is, if the suspicion for bleeding is low at the end of the case and you have an abnormal ROTEM, our ICU, our anesthesia team will order the blood products for us, or even bring it with them and give it to us. We try not to transfuse unnecessarily. So we'll observe them in the ICU. If the suspicion is low, we send the blood back. Obviously, if there's concern for bleeding, we give it. The role of TXA and Amicor, I think we don't really need to talk much about it. There's been a lot of data showing everybody should be receiving these medications to prevent clot breakdown, and should be standard of care in patients undergoing on-pump cabbage. For our institution, like I think Dan mentioned before, we're mostly an off-pump cabbage center. We give TXA to all of our off-pump cases. We have not seen any adverse outcomes related to it, and I think it should be standard of care that everybody should receive this medication, because the harm is very little, but it does decrease your complications of bleeding post-op. And in the ICU, in the post-operative phase, the most important thing that we need to establish is good communication. There has to be a way of communicating your concern for bleeding, documenting it, and addressing it. And this starts with having a bleeding algorithm that kind of takes into account the culture in your institution, but also your surgeon's preference in terms of how they want to manage bleeding, because this allows the team to know what to expect next. And sometimes it kind of moves the process fast for you, and they'll start doing things knowing this is your next step in your bleeding management algorithm. Simple things like communication, it's very simple, but this is our bleeding algorithm. Making your tubes, checking your tubes and making sure that they're patent should be integral in your bleeding management. Obviously addressing your labs as quickly as possible. And the other thing that I think we always forget when we talk about bleeding algorithm is understanding your blood bank. So every blood bank has its way of working, especially in New York City. Sometimes there's shortage of certain types of blood. So you really have to know what your blood bank is capable of doing. Do they have constant shortages of blood products? Do they take a long time to prepare certain types of blood products? So you have to incorporate that into your bleeding management in the postoperative period. And lastly, hemostatic agents like PCC and Novo-7 are gaining some popularity in cardiac surgery. I think a lot of the data that we have right now is really anecdotal and kind of single center based, but talking about the use of these agents in the postoperative period should be incorporated in our bleeding management. There is no randomized trial looking at PCC in cardiac surgery patients. This is the one that recently was published in JAMA Surgery. In this case, they actually gave PCC in the operating room when they saw patients, and at the end of, this is all dedicated to on-pump cases, at the end of the case, if they saw microvascular bleeding, they put patients into two arms. One arm got FFP, the other arm got PCC. And what they saw was the big fear that we have about using these medications is thrombotic complications, especially in our CABG patients. And this study actually showed it's safe to give prophylactically in CABG patients. The limitation being there weren't really a lot of CABG patients in the study. It's mostly other cardiac surgery patients. So there may be a role in CABG, we don't know. But you could definitely, there's no CABG program that does isolated CABGs, right? We all do a mix of everything. So there may be a role of using these medications in our cardiac surgery program. The hemostatic agents that we use in our institution, the most common one is PCC, and it comes in two formulations, either a 3-factor or a 4-factor PCC. These are essentially vitamin K dependent factors that you're trying to give the patient back. The advantage is you're giving a higher concentration of factors, about 20-fold compared to plasma. So you're giving a lot of factors in a small volume compared to tons and tons of FFP, so you may decrease the complications that you see with blood transfusions. There's no blood compatibility you have to worry about when you give PCC to your patients. The use of Novo-7, I think, is quite controversial. I would say we should avoid it definitely in our CABG population. There may be some role of using Novo-7 in complex aortic cases and reoperations. So going back to our patient, she actually bled a lot. The concern at this point was not a microvascular bleed. We actually were worried there was a hole because she was bleeding. We ended up giving her tons of blood products. We activated the OR to take her back for exploration. But the other part of it that we always deal with in the ICU is you can never take patients back to the OR as quickly as you want to, right? It takes a lot of planning and coordination. But she kept on having ongoing bleed, so we ended up giving her PCC, which actually interrupted her bleeding, and she did not need to be re-explored. So the data regarding PCC is also, in times that it was given, it actually has aborted the need for re-exploration, which is very important because re-exploration in itself increases the mortality and morbidity of our patients by 4-fold. So if we can avoid it with little complications, probably worth discussing it in these kinds of situations. So I have a few minutes left. The next one is rhythm. Arrhythmia is probably the second most common issue that we see, and this is a straightforward CABG that ended up having, on day one was sitting in chair, and then all of a sudden he became unresponsive and was found to be in VT and pulseless, needed to have CPR to resuscitate him. So what do you do in these cases? The most common arrhythmia we encounter is actually atrial arrhythmias, like atrial fibrillation. We all know about a third of all patients that undergo cardiac surgery likely will have some atrial arrhythmia. The PAPA trial that was published in 2005 has actually shown us amio is actually beneficial as a prophylaxis in patients undergoing cardiac surgery. Ami will talk about this soon, but we have data in our institution using low-dose amio to prevent AFib, and she'll go over the data, but we have seen a 10% reduction in AFib in patients that receive amio. The second most common rhythm problem that we see is actually PVCs, which is very common, related to electrolyte issues as well as reperfusion injury, but it can lead to bad events, so we really need to pay attention to it. Whenever you see a sustained ventricular arrhythmia, that really is a big problem that needs to be addressed right away, and I think we all know how to manage that. But in terms of PVCs, how do you manage them? If you have atrial wires available, they're actually an asset. We typically pace our patients until we optimize their electrolytes just to avoid the small chance that they could go into RNT and unwanted ventricular arrhythmia. The debate whether lidocaine versus amio, which one should you use in terms of persistent PVCs, I'll leave that up to you. That's also another institutional preference, but there's a lot of evidence, more older evidence, supporting the use of lidocaine because it's thought to be more cardioprotective in the cases of ventricular ectopy. We use amio, and rarely we kind of use lidocaine when we feel the amio is not working. So this patient, when we reviewed, actually ended up having PVC-induced ventricular arrhythmia, RNT. He did end up getting a cath just to complete his workup. His grafts were patent. He did get a kind of an emergent urgent balloon pump in the setting of his code. He recovered nicely, but out of abundance of caution, he ended up getting an AICD prior to discharge. Another point that we should kind of stress in this situation is mock codes and having your team participate in active resuscitation of your patients. Especially in most ICUs, and maybe this is related to COVID, there's a huge turnover of our staff, right? We're constantly getting new staffing every so often. So making sure that your team knows what to do when a bad event happens should be an integral part of your daily care. So we routinely do mock codes. We try to do it quarterly. Sometimes we do it a little bit more often depending on how busy we are. But having active mock codes and case scenarios so that your team knows what to get in this situation is actually key and very important. I may be like 2 minutes over. Shock is that, this is probably very common and something that we deal with every day, but shock management to me is like, when you go to a new institution, is like talking about religion or politics, right? Everybody's committed to what pressor or inotrope that they use, and even though there's a lot of data supporting one versus another, it really becomes an institution culture that you're dealing with. What I have learned is pressors are pressors, they work. Inotropes are inotropes, they work. Where you have to kind of have a nuance is when something is not working, you have to be able to adapt and convince your team to try something new. We work in an off-pump CABG center, so most of our patients are aggressively fluid resuscitated in the operating room. So for management of hypovolemic shock, I would say limit your resuscitation to 2 liters in the postoperative period because they've already gotten so much fluid. If it's not working, you probably need to do something else. So don't flood patients just thinking their CVP is low or they have respiratory variations. I think CVP is a little iffy in terms of assessing your fluid status in the postoperative period. You really have to look at multiple things like urine output, CVP, PAD, sometimes echo to help you guide fluid resuscitation in the postoperative period. Cost is an issue nowadays, but colloids should always be part of your fluid resuscitation effort in the immediate postoperative period. Shock management, again, people are very sticklers about what inotropes they like and they don't like. Don't fight that battle, it's just not worth it. Go with the flow and give whatever inotrope that your team likes to use. But try to change their mind if you feel like something is not working. But the most important thing is to consider mechanical support if you feel like the patient is not responding, and do that as early as possible because you don't want to start seeing end organ dysfunction when you start considering putting mechanical support in patients. Vasoplegic shock, which kind of ties into what the previous talk was about. Vasopressin is obviously the first line agent that we use, but medications like methylene blue, cyanocat, and if you have it, which is quite expensive, but angiotensin II can be used for a management of severe vasoplegic shock. I have seen a very devastating case of methylene blue, so I shy away from methylene blue as much as possible. I think my go-to agent is probably cyanocat as early as possible. And then if you are considering methylene blue, please review the patient's prior medical history before you administer it because you'll be plagued the rest of your life if you experience serotonin syndrome. And then lastly, neurologic complications. This is something that we really don't have full control over, right? Unfortunately, strokes are a risk associated with any cardiac surgery and CABG in general. There is some data to support the use of off-pump CABG and aortic CABG strategies may help you minimize the risk of stroke. I don't think that data is really clear. But at our institution, a bulk of our patients get anaortic off-pump CABG, and this is one patient that ended up getting off-pump CABG, which was anaortic, unfortunately had a devastating basilar stroke. So strokes happen. There's really not much you can do about them. And I don't think there's much pre-optimization you could do as well. It's just one of those things that you have to deal with. But the dealing with part is really trying to understand if the patient had a stroke as early as possible, because the two types of strokes that you want to recognize are a bleeding stroke, so you can intervene on it, or a large occlusive stroke. And this is where your ERAS process may help you as well, because early termination of your sedation and using Precedex starting in the OR will help you wake up your patients as early as possible so you can assess their mental state. And then, I love Precedex. I think everybody should be on Precedex. So I think it helps with pain, it helps with anxiety. I know there's a lot of delirium associated with it, but we use it for delirium, so I think it's just a great drug to use whenever you can start it. So we try to start Precedex as early as possible in the immediate postoperative period, unless there's concerns to keep patients sedated. And then whenever in doubt, try to go back and see how much paralytics and narcotics your patients received and try to reverse that. Medications like Sugamidex and Narcan are actually quite helpful, because if you give it early, they don't respond. That's usually a signal that something is not right. So you might want to image those patients as early as possible. Hopefully I didn't talk too long, and that's it.
Just out of curiosity from the audience, how do you all handle Plavix and Brilinta? What's your go-to point where you say, okay, we can take the patient to the operating room? Is there a Plavix assay number that you look at? Do you do RO10s? Do you do TEGs?
We just wait at my hospital. We just wait 3 to 5 days, depending on what their status is, and we just take them then. So we'll optimize them throughout that time, and then afterwards, we take them.
Do you do Plavix assays or?
No.
Just
That's
tincture.
I'll call Texas.
but like I said,
Town in Texas, all right?
that's actually the standard practice in most institutions. A lot of hospitals don't have access to P2Y12 assays, so most places wait 3 days for Brilinta, 5 days for Plavix, and then 7 days if you happen to be on prasugrel, and then they take you to the operating room. So I think the P2I12 assay, I'm always iffy about it, because we just wait for that perfect number, and your patient is in the hospital bedbound, not walking, because you're worried about angina symptoms for 7 to 10 days. And I'm wondering, is that helpful or harmful? Like, you're trying to prevent one problem, but you may be causing another problem as well. I did have one question. Has anybody used PCC in the setting of CABG for bleeding management? No? Nobody? I think that really should be one thing hopefully we get to look at, because we have, at different institutions, it's become kind of routine to use PCC prophylactically in cases, complex aortic cases, reoperations, and valve surgeries. And the risk of stroke being the big one that we always worry about, the risk of stroke or other clotting complications is very small. But we really don't know how it plays a role in CABG program, especially in off-pump CABG, where you have a lot of anastomosis that you have to worry about. So I think seeing that data in the near future would be great. That's it.
Thank you so much.
Good morning. Today, I will be presenting on surgical site infections, understanding, prevention, and management. Today's presentation objectives are the following. What is a surgical site infection? What are the risk factors? How to determine risk, classification, prevention, and intervention. So what is a surgical site infection? A surgical site infection occurs after surgery in the part of the body where the surgery took place. Surgical site infections can be superficial, only involving the skin, or it can be deep, involving muscle fascia, organs, or implanted material, making them more difficult to manage. Some brief overview regarding surgical site infections. According to the CDC Healthcare Associated Infections Prevalence Survey, there are over 100,000 documented inpatient surgical site infections since 2015. SSI accounts for 20% of all hospital-acquired infections. 20% is a significantly high number since hospital-acquired infections also include CLABSI, CAUTIS, VAPS, and C. diff. SSI is also associated with high mortality rate, with an annual cost of $3.3 billion, and an SSI can increase a hospital stay to 9.7 days. Some generalized symptoms of SSI are redness and pain around the surgical site, drainage from the surgical wound, fever, and delayed healing. What are some of the risk factors? Microorganisms. Staph aureus, MRSA, coagulase-negative staph, gram-negative bacilli are one of the common causes of surgical site infections. Patient-related factors. Age. Older patients may be at higher risk due to decreased immune function. Nutritional status. Malnutrition can impair wound healing and immune response. Poorly controlled blood sugars can hinder the body's ability to fight infections. Obesity. Adipose tissue is less vascular, reducing the effectiveness of systemic antibiotics. Immunosuppression, any condition or medications that suppress the immune system. Smoking impairs wound healing, and coexisting infections. Some surgery-related factors are duration of surgery. Longer procedures can increase risk of SSIs, which means the chest has been remaining open, or how long patients are on bypass. Surgical technique, inadequate sterilization, or the actual surgical technique can introduce pathogens to the chest cavity or to the donor sites. Some cardiac surgeries have an inherent higher risk of SSI, implants or foreign bodies. Also, some environmental factors are operating room environment, contamination of the environment, including air quality and unsterile equipment. Usually in the operating room, there is positive pressure to keep the organisms out of the room, as when we do negative pressure for TB, we like to keep the organisms in the room, not to affect the outside environment. Some other factors are including inappropriate choice, dose of timing of prophylactic antibiotics, and inadequate skin cleansing. How do we define risk? The STS Operative Risk Calculator is a tool developed by the Society of Thoracic Surgeons, STS, to assess the risk associated with cardiac surgeries. It takes into account various patient-related factors such as age, medical history, and specific procedure details to estimate the likelihood of complications or mortality following cardiac surgery. This calculator aids healthcare professionals in evaluating and communicating potential risks to patients undergoing these procedures. The STS calculator can assist the healthcare provider in individualizing a care plan based on the predicted score. And as you can see on the screen, we have a copy of the STS calculator. The healthcare provider enters details as what type of surgery, demographics, lab values, medications, comorbidities, also if there's coronary artery disease, valvular disease, or arrhythmias. After all this information is inputted, you get a simulated patient study, and on the side you can see it gives you a percentage of how often this complication would occur in your patient, and you can see where the red circle is. A deep sternal wound infection is one of the things this calculator measures. According to the CDC recommendations for prevention, patients are to clean from their hands to the arms to the elbow with antiseptic soap before surgery. Also, healthcare providers need to wash their hands in and out of rooms. We need to also remove hair before surgery. In the operating room, OR personnel needs to wear special hair covering, mask, gowns, and gloves during the surgery. Also, antibiotics and a specialized soap to clean the skin. So not all wounds are considered surgical site infections. So what is considered a surgical site infection according to the CDC? As you can see here, we have a table that goes over the different types of surgical site infections with their inclusion criteria. So if you see here on the side, you see the criteria, you have infection timing, infection depth, and then you have to meet one of these criteria down below to be considered a surgical site infection. So we have our superficial surgical site infection, which occurs within 30 days. It involves the skin and subcutaneous tissue only, and it has to have one of the criteria below. Purulent drainage, organism identified, a wound that is deliberately opened by a surgeon, and one of the following symptoms: localized pain, tenderness, swelling, or erythema or heat, or a diagnosis of a superficial surgical site infection by a physician or a designee. Now we go over to our deep surgical site infection, which is within 90 days from surgery, and it involves deep soft tissue, muscle, and fascia. And then you need one of the following criteria below: purulent drainage, and in addition to a surgeon opening it deliberately, there also is spontaneous dehiscence, and with a positive culture, and with one of the following symptoms: fever, localized pain, or tenderness. And then the last criteria is an abscess or evidence of infection. Then we have our organ space surgical site infection, which also occurs within 90 days, and that is deeper than the muscle and fascia. And then it has to have one of the three criteria, 1 to 3, and criteria 4. So it has to either have purulent drainage, an organism identified, an abscess or other evidence of infection, and it needs to have a specific organ site designee, and I will show you that table on the next slide. Then we have our donor site infections, which are within 30 days. And this can involve the skin, subcutaneous tissue, muscle of the donor site. So when we say donor site, we're talking about where we get our saphenous veins and our radial arterial grafting. And the criteria is similar to superficial or deep, depending on the depth of the donor site infection. And as you can see here, this is the table for a specific site of organ space. So if you do not meet one of these sites, you cannot have an organ space surgical site infection. So some of the interventions we've done. So our original interventions were we dressed all our wounds with dry gauze with Benadine. We also treated patients with 5 days with Bactropam nasally. And with that, it posed complications because how do you know the patient was compliant at home? How do you know they were doing it correctly? And how about if you don't have a full 5 days before the surgery? So then you can't finish the full course of treatment. On discharge, they were getting their follow-up appointments in the office 20 days after. And we did 2 chlorhexidine baths night before and morning of. But once again, how do you know patients are compliant and doing correctly at home? So with discussion of the team, we reviewed the evidence-based practice, and we came up with prevention and interventions for surgical site infections. So one of the things we did, we changed the Bactropam nasally to a one-time nasal swab that is done in the pre-op holding area. This ensures it's getting done, and it's getting done correctly because it's being done by a healthcare professional. We also changed the dry gauze dressing to Aquacel AG. The manufacturer recommends that this dressing stay on for 3 to 7 days post-op. In the beginning, we were keeping it on for 7 days, but then we noticed it was getting very mushy and just not looking like it was doing its job anymore. So now we take it off on post-op day 3. So what is Aquacel AG? It's a dressing that is primarily composed of sodium carbomethylcellulose, CMC, and silver. CMC is a water-absorbing material that forms a gel when in contact with wound exudate, promoting a moist wound environment. The addition of silver serves as an antimicrobial agent, helping to reduce bacterial growth in the wound. Overall, Aquacel AG is designed to manage wounds by providing a combination of moisture control and infection prevention. We also started using topical vancomycin paste. It's applied to sternal wounds upon opening and closing. Vancomycin paste has been studied across a number of RCTs, demonstrating reducing the incidence of deep sternal wounds. Also, what we did was we increased antibiotic dosing adherence by continuous chart reviews and education. The metric is that the vancomycin infusion must be infused 20 minutes or more prior to skin incision, and cefalozine redosing every 4 hours after the initial pre-incision dose. And as you can see, this was our prevention. And now we go to intervention, because sometimes no matter what your best preventions are, you can start developing wounds. So you also have to have evidence-based interventions to make sure that your wounds do not progress to a surgical site infection. So some of the interventions we used is VOSH. VOSH is a wound cleanser that contains hypochlorous acid as its active ingredients. Hypochlorous acid is a mild antimicrobial agent that can help in wound cleansing and management. It is often used for its antibacterial properties, and also being gentle on the skin. So we also changed how we followed our patients in the office. We started with 7 days and then 28 days, and more frequently if a wound develops. We also did twice-a-month interdisciplinary meetings where we reviewed any patient who started developing any type of wounds. Also, we initiated upon discharge that they would get a picture of their sternotomy and their donor sites that were uploaded into Epic, and on every visit, we would take additional pictures so we can see progression. So, our interdisciplinary meeting, who attends? We have surgeons, PAs, MPs, intensivists, nurse managers, bedside nurses, perfusionists, anesthesia, infection control, anesthesia, OR, and visiting nurse services. VNS is crucial in the transition to care since most wounds develop in the home setting. What do we discuss during the meeting? We discuss what the wound looks like. We discuss glucose levels, nutrition, fluid overload, depression and family support, antibiotic choice and dosing, dressing types, home care, utilization of surgical bras, and care plans. So we start each meeting with a slide that looks like this. We have our patient's name, the surgeon, the assistants, the surgery date, the surgery type, risk factors, hemoglobin A1C, highest glucose in the hospitalization, and if the antibiotic dosing was correct. And we've just recently added surgery time. So, this is one of our patients that we had. You could see 6-5 was the initial discharge picture. And you can see the patient didn't come back to the office in 7 days, but you can see they came back in 10 days. And you can see we have already starting to develop some type of wound. So this patient was seen almost every 10 days up until August, where you can see the wound was actually healed. During this meeting, we actively created a care plan for this patient based on these photographs and also from the feedback from the MP in the office who were managing these wounds. Also, in addition, as we're developing this care plan and we're reviewing everything that we've done for this patient, it's also an opportunity for us to see if there were any gaps in care so that we can close those gaps, create interventions so that this doesn't happen to a next patient. So how did we do? So from 2017 to 2023, we've had a total cardiac procedures of 2,212. The blue bar is our raw number of SSI. The blue line is our rate, which is our infection rate per 100 procedures. And you can see in 2017, we had a raw number of 4 SSIs with a rate of 2.6. Where you see the red arrow, that is where we started our intervention, and you can see that we have dramatically decreased our SSI rate. Also note that all SSIs that meet criteria are reported to the National Healthcare Safety Network of the CDC. So this bar graph is a different representation of how we're doing with surgical site infections, and this goes over the standard infection ratio, the SIR rate. The standardized infection ratio is a statistic used to track healthcare-associated infections over time at a national, state, or facility level. The SIR rate compares the actual number of hospital-acquired infections at each hospital to the predicted number of infections. And that goes back to what I said before. No matter, sometimes with the best prevention, there is sometimes an expected surgical site infection that will occur. The SIR rate is calculated by dividing the number of observed infections by the number of predicted infections, risk adjusted. So risk adjusted takes into account the STS factors, their morbidity, and other conditions, because some surgical site infections are not preventable. So if you notice, when we say observed over predicted, that means the amount that is expected based on your patient's demographics, you should have the same amount of SSI, which would make your ratio benchmark 1. But if you notice that our benchmark is below 1, it's 0.6. Even though the slide before, we had a rate of 2.6 with a raw number of N. This just means that we should have had more expected SSI than we did, and that's why our ratio is below the benchmark. Also, if you noticed in 2018 and 2020, from the previous slide, we did have SSIs for those months, but according to the National Healthcare Safety Network, it did not meet their criteria to go into the SIR rates. So overall, you can see we're doing very well. So some final thoughts. Avoidable is having the best practices in prevention. Unavoidable is to have best practices in intervention to ensure wounds do not progress to surgical site infections. Interdisciplinary approach fosters all the unique training and focus of each specialty of the cardiac team to promote the best care of plan for the patient. There always has to be constant surveillance. If you're not looking at your patient, if you're not talking to your patient, How do you know if their wound is progressing or healing, or if they're even developing a wound? And if you look back at those pictures, if we didn't see that patient in 10 days and we waited 30 days, what would have that wound looked like? It probably would have looked a lot worse than when we saw it within 10 days. Also, standardized workflows. When you have standardized workflows, you're providing the right care at the right time for every single patient, and there will be no gaps in care, and everyone will receive the same treatment at the same time to prevent SSIs. Thank you. Any questions? Okay, so our next speaker is going to be Ami Shah, PharmD. She is the Cardiovascular Medical Affairs for Johnson & Johnson Innovative Medicine. She's going to be giving 2 presentations today. One is amyoprophylaxis against postoperative AFib in off-pump CABG, and inhaled pulmonary vasodilators in cardiac surgery.
All right, guys, thank you so much for that introduction, Shauna. Before we start, I'm going to let you guys take a 30-second stretch break because I know we've had a long morning, so if you want to just get up and stretch before we get started.
All right, go on.
How do I, I'm not able to see my slides on this portal
I'll
here.
get that one, John. I'm sorry,
Thank
that's
you.
my fault.
Oh, that's okay, thanks. Thank you. All right, everyone, in the interest of time, we'll go ahead and get started. My name is Ami. For those of you who don't know me, I'm a board-certified critical care pharmacist, previously working at Mount Sinai Morningside with the cardiothoracic ICU team. Oh, sorry about that. Can you all hear me okay? Wonderful. So like I said, my name is Ami. I'm a board-certified cardiothoracic pharmacist, previously working with the Mount Sinai Morningside team. Today we'll be talking about the efficacy and safety of a standardized amiodarone protocol, specifically in off-pump CABG patients. So before we even get started, with the show of hands, can anyone tell me have you heard of an amiodarone preventative protocol in your practice before? Yeah. Wonderful. And how many of you actually implement one at your programs? Outside of the Morningside team, because I know that's something that we've worked on.
Well, we did, but we had a cardiologist that had some concerns, so we just continued to practice.
Absolutely, and I'm really happy you mentioned that because there is, although there's favorable data overall, a lot of the protocols are so varied that the results are also varied. So I think one of the biggest factors that we'll be talking about today is making a protocol that's manageable and you're able to implement it both in the preoperative, perioperative, and postoperative periods. In terms of disclosures and acknowledgement, I have moved on from Morningside and I currently work at Johnson & Johnson, so that is my disclosure for today, but hopefully we won't be talking about anything that would be conflicting of interest here. I do have some acknowledgements here on the side. Of note, Dr. Yiman, Dr. Puskis, Dr. Bott, and Shauna Friedman. The objectives of today, like we talked about, is to evaluate the impact of a standardized low-dose amiodarone protocol, specifically in high-risk surgical candidates, and we'll talk a little bit more about what that means in a bit, and to discuss these research findings on future implications. So to give you some background, we all know what postoperative AFib is, but it's new onset AFib in the immediate postoperative period, characterized by brief, asymptomatic, and paroxysmal episodes. I know this number was thrown up before, but I think Dr. Yeaman referred to it as 1/3 of patients, but 30 to 50 is really what that percentage is. I highlighted it here because we want to talk a little bit about what the impact of our protocol has been and what the data shows of what that percentage looks like. Some patient-specific factors: female gender, age of greater than 75, an EF less than 40, hypertension. Some additional factors would be the amount of graft manipulations and if it's an on-pump versus an off-pump procedure. Now, in terms of the epidemiology, this bar graph just shows you the type of procedure on the x-axis from left to right. So first we start with isolated CABG, then univalvular, CABG and valvular, followed by multivalvular. And the p-values here just help you show how they compare to one another. So an isolated CABG and univalvular are the lowest, followed by CABG plus valvular, and multivalvular just increases your risk. Now, the one thing I want to point out, we talked about the 30 to 50%. I put it in a red box here for you because the one thing I do want to highlight is that a lot of the patients that were evaluated, they differ in the type of patient population that was studied, including in terms of the regimens. So today we'll be talking specifically about off-pump CABG patients, but I'm certain that if we're able to show results in the lowest risk population, that if we then studied CABG plus valvular or even multivalvular patients, the results would be even more greater. So here are the current guidelines for you. I know this is a little bit of a busy slide, but we're going to start with the US guidelines. Right in the left, we have the 2014 guidelines that was followed by a 2019 update. Of note, there have been no updates until, as of yesterday, the 2023 guidelines for AFib were released. In those guidelines, the recommendations are relatively similar to the 2019 update that was there. So they recommend in the pre-operative period that amiodarone is reasonable as a prophylactic therapy for patients at high risk of postoperative AFib. Comparing that to the 2020, in the second column, the 2020 ESC guidelines, they recommend preoperative and postoperative, and they use the word that it's recommended. The CCS guidelines recommend that it should be used for any patients with a contraindication, only to those with a contraindication to beta blockers, so no other patients. And the 2019 guidelines, all the way on the right side, they recommend it in the preoperative and postoperative period, and they recommend that they support the use, again, in high-risk patients. Now, the reason I read all of those to you is because you'll notice slight variation in those words there. You'll also notice that a lot of times the word high risk is thrown out there, but there is no definition of what that actually means and how we can implement it in our patients. The type of patients that were looked at in the guidelines that's in the box here for you, they look at cardiac surgery patients, but no additional surgical qualification. Was it off pump? Was it on pump? Did it include valves? It just leaves it up to cardiac surgical patients. The amiodarone dosing, also not established. They recommend that the risk is either reasonable or supported, but they don't actually recommend what type of dosing should be utilized for these patients. The level of evidence is listed here. A lot of them have a strong level of evidence. Of note, the 2023 updates that did come out, they actually reduced the level of evidence, kept it as a class 2 recommendation, and reduced the level of evidence from an A level to a B level. Now, this is taken from the European guidelines, but I like this schematic mainly because you can see very clearly the green is a level 1 recommendation and is pretty much adopted by most programs in the country. Use beta blockers to avoid withdrawal from pre-op to post-op. Moving even further down, administer beta blockers in the postoperative period, continue beta blockers to avoid withdrawal in the pre-op through post-op period, and then administer beta blockers again in the post-op period. The one that I'm going to highlight is the one in yellow, so prophylactic amiodarone. It's as we talked about already in the guidelines, uncertain, strong level of evidence, but it's not used as frequently as we would like. This does characterize and differentiate between elevated risk and normal risk patients, and you'll note that the prophylactic amiodarone is specifically, as the box demonstrates, in the elevated risk patients, not necessarily in the low risk patients. What that means, we'll talk about in just a moment. But here was a study that I like to characterize. On the x-axis, you see the CHADS-VAS score. This is patients with no postoperative AFib, and when we're looking at these patients, you see that their CHADS-VAS ranges from 1 to 4. The reason that's relevant is if you compare it directly to postoperative AFib patients and you look at that CHADS-VAS, you'll see that generally the patients that develop postoperative AFib have a higher CHADS-VAS score. So you'll see in the box here 2 to 5, and that's usually the range. And the reason I bring this up is because this is helpful to identify what we call high-risk patients. This slide is very busy. The reason I bring it up is mainly to show the literature that has been done. There's very few RCTs, more retrospective reviews. In the RCTs that have been done, there have been varied patients and varied interventions. The one thing I would highlight here is not for you to know everything in the box, but just to know that even if you look at this box individually, you'll see it ranges from starting on post-op, preoperative day 6 to post-op day 0, and continues until post-op day 6 until post-op day 14. There's high variability here. Even in terms of the regimens used, it changes between PO and IV, some as much as 10 mg per kilo per day, some as little as 200 milligrams orally. There was only one study that specifically looked at a high CHA2DS2-VASc score, and we talked about that CHA2DS2-VASc score just a few slides earlier to differentiate what a high-risk patient population would be. And this study specifically looked at a CHA2DS2-VASc greater than 3. So now I'll characterize the study that we did at Mount Sinai Morningside. The goal in the intervention here was to assess the safety and efficacy of a low-dose oral amiodarone protocol. We looked specifically in off-pump CABG patients because we're an off-pump CABG center. And we looked at high-risk patients, which we defined as a CHA2DS2-VASc greater than 2. Again, a busy slide, but this just characterizes what our protocol is. So our protocol starts in the preoperative period. The goal is to continue implementing it in the preoperative period, although due to bradycardia and concerns of who's actually monitoring these patients, it's been slow to implement. But the goal right now is for only inpatients, patients who are admitted preoperatively but still as an inpatient, to load them with amiodarone. It's a weight-based loading protocol. If they're less than 125 pounds, 200 milligrams orally twice a day, and if they're greater than 125 pounds, 200 milligrams orally 3 times a day. Moving into the intraoperative period, for patients who were inadequately loaded, who did not receive this preoperative dose, they would get 150 milligrams IV once in the OR prior to skin incision and once again following protamine administration. Of note, our center did implement temporary prophylactic epicardial wires for these patients. And in the postoperative period, all patients received a low-dose prophylactic oral amiodarone regimen of 200 milligrams twice daily, administered orally, initiated 6 hours postoperatively, continued until 15 doses or discharge. Of course, we have exclusion criteria, so if they ever developed any type of bradycardia, this protocol would be aborted, or if they developed AFib, this prophylactic protocol would be aborted and treatment doses would be initiated. Our objectives, the primary endpoint is the incidence of new onset AFib. The secondary endpoints are listed here. I don't want to read all of them to you, but they're here for your reference. Safety endpoints, of course, the adverse reactions of amiodarone, bradycardia, QTc prolongation, and the rest are here for your reference as well, but not unfamiliar to those relative to amiodarone dosing. Our patient population, on the left, we have our inclusion criteria, so patients greater than 18 years of age, isolated CABG, CHA2DS2-VASc greater than 2. The regimen is listed here. It was a retrospective study of note, but we are comparing a retrospective control group of who had varied doses of prophylactic amiodarone, and then a prospective cohort who had the standardized dosing that I just read to you. Of note, the standardized dosing included the preoperative, intraoperative, and postoperative components. The exclusion criteria are listed here. Any canceled procedures of CHA2DS2-VASc less than 2, patients who had amiodarone prior to enrollment, known yet untreated thyroid disease, class 4 heart failure, severe hepatic dysfunction, history of AFib, urgent or emergent cases, and robotic procedures. This is a busy slide, but I just want to clearly demonstrate what our results were. The one that I would highlight is that our patients in the study group did seem to have a statistically significant increase in terms of their CHA2DS2-VASc score. There were greater patients in the control group who had a CHA2DS2-VASc greater than 5. So that does skew the studies, and of course that's one of the limitations of a retrospective study to begin with. In terms of history of chronic disease, there was an increase in terms of patients who had heart failure and COPD in the control group. Again, a limitation and a propensity match study in the future would be helpful in this patient population. Baseline of home medications were relatively similar throughout groups. Intraoperative characteristics, there's 2 that I would highlight, the number of grafts and the procedure duration. In this situation, actually, our study group had higher number of grafts and a higher procedure duration. These were the results that were noted. Again, I'll mention that number 30 to 50%. So just to orient you to what you're looking at, you're looking in the blue is our retrospective cohort, and in the darker blue or purple is our prospective cohort. We're looking at 2 outcomes. One, that's AFib necessitating treatment, and two, AFib necessitating treatment at discharge. So if we're looking at the left first, we have AFib requiring treatment. We have 25% in the control group, which is relatively similar to that 30% that we were benchmarking. And then we have a decrease, as Dr. Yeaman mentioned, of 10% in our prospective group down to 14%. It was a statistically significant finding. And similarly, for AFib necessitating treatment at discharge, 10% reduction noticed there. Postoperative characteristics, this is just a numerical value listed here. Postoperative medications of note, our amiodarone usage in our study group was higher, but that was expected since we're giving everyone preoperative and prophylactic amiodarone. No adverse events, differences noted here. And in terms of summary and future directions, the use of a low-dose amiodarone protocol resulted in significant reduction of postoperative AFib without introducing side effects from the medication. Significant reductions were noted in time to extubation and the percentage of patients requiring AFib treatment at discharge. The conclusion here is that the protocol could be considered safe, effective, and feasible for implementation in high-risk off-pump CABG patients. And future directions would include a long-term analysis, specifically a propensity-matched cohort to mitigate any confounders, and investigation of newer delivery systems. Of note, there's been new data looking at the epicardial delivery of amiodarone, such as amiodarone gels in the OR. Further studies in on-pump CABG and valvular patients are needed. One literature update that I did want to note, this research was conducted a few years ago, but just in this past year, there was a very first large observational trial looking at the association of amiodarone treatment and outcomes in routine clinical practice. Previously, as I mentioned, there were very few RCTs, some small retrospective reviews, but this is the first large observational trial done. They had over 12,000 patients across 230 hospitals. They did use elective coronary bypass procedures. They did have a mixed population, so they had about 80% patients of CABG and then around 20% CABG plus valve. 10,000 of them did not receive amiodarone. 2,000 of them did. So of course it's not an RCT, it's a retrospective review, it has its limitations, but again, it's the first large study that was conducted. And in reviewing those patients, perioperative amiodarone was defined as treatment of amiodarone either on the day of or preceding surgery. So the regimens were not standardized here. But it was found in this review that the perioperative amiodarone was safe, effective at reducing the occurrence of postoperative atrial arrhythmias and was reduced with a shorter length of stay, which aligns with the study that we did locally and aligns with our results as well. That concludes today's presentation. Does anyone have any questions? Okay, I think you guys are stuck with me for another 20 minutes as we talk about another conversation. I don't see it up on here yet. Thank you. Wonderful. Thank you guys so much. So today's next presentation would be inhaled pulmonary vasodilators and cardiothoracic surgery. Disclosures we already talked about, the same disclosures from previously. The objectives of this presentation would be to differentiate pulmonary hypertension classifications, to analyze mechanisms that contribute to pulmonary hypertension after cardiac surgery, and to evaluate the role of vasoactive medications and inhaled pulmonary vasodilators. So there's 5 different classifications of pulmonary hypertension from the WHO. Of note, we'll be talking about the second classification, which is pulmonary hypertension associated with left heart disease. There are some different characterizations as we go through these that refers to precapillary and postcapillary, so we'll talk about that a little bit. Class 1 is known as pulmonary arterial hypertension, so that's usually the precapillary phase associated with idiopathic or heritable conditions. The prevalence is listed there on the bottom for you. The second, which is the most relevant to us, is pulmonary hypertension associated with left heart disease, otherwise known as postcapillary disease. The abbreviations here are either isolated postcapillary or combined, which is just precapillary and postcapillary combined. The classification for the third is associated with lung disease, severe pulmonary hypertension, also prevalence pretty high. The fourth classification is associated with pulmonary artery obstructions. And the fifth is unknown, either hematologic or systemic disorders. The hemodynamic definitions are here for you, but again, just for reference, I don't think many institutions actually evaluate these numbers, and the call out that's on the text box to the right is that the use of a pulmonary artery catheter during CABG surgery was associated with increased mortality and higher risk. So unfortunately, a lot of these numbers are just for reference for definition's sake, but not actually routinely used in clinical practice. Cardiac surgery, in terms of the different risk factors specific to cardiac surgery, there's quite a few, but the schematic kind of just depicts all of them. One would be underlying pulmonary hypertension. The second, which is the most predominant, is left ventricular dysfunction. The third is pulmonary inflammation or ischemia. Fourth, which is interesting, since I'm a pharmacist, protamine administration. It has been associated with increased risk of pulmonary hypertension and unfortunately unavoidable in our patient population. Fifth is mitral patient prosthesis mismatch or post-op valvular dysfunction. Sixth is hypoxia and hypercapnia or pulmonary emboli. And seventh is positive pressure ventilation. Over time, the reason that we even talk about this is that over time it goes from compensating to decompensating to failing. The one thing that I would highlight is the red arrow, that's PVR or pulmonary vascular resistance, that continues to go up. And over time, if you let this go on, your blue arrow or the cardiac output will continue to go down. The earlier you catch this, the better. There is what we call a right ventricular death spiral, as you see here. So the pulmonary hypertension that starts on the top will lead to right heart failure, eventually cardiogenic shock and death. As we go down the pathway, we see a decreased coronary perfusion, decrease in systemic blood pressure, decrease in cardiac output, decrease in LV preload, and decrease in RV output. The red call-out box is what we're going to be talking about a little bit further today, which is the PAH treatments, whether that be PAH-targeted therapies, diuretics, supplemental oxygen, or AV synchrony that helps kind of remove the decoupling of the RV to PA to be a more coupled phase between the two. The World Health Organization, as we talked about, has 5 different classifications, and the one call-out box here is that since we're talking about group 2, the recommendation for treatment there is a very vague treat underlying cardiac etiology, which, as you all probably know, is very dependent on who you're working on, both the patient and the institution. So the call-out box that's on the bottom is that the treatment of PH plus or minus RV failure in the OR and ICU relies primarily on expert opinion due to the absence of international recommendations or consensus on management. So some of our perioperative hemodynamic goals, we're going to be looking at optimizing fluid status, mitigating factors known to increase PVR, such as hypoxia, hypercarbia, acidosis, hypothermia, maintaining normal sinus rhythm, mechanical support, avoiding high airway pressures, and positive end expiratory pressure. The next is going to be maintaining RV perfusion, and we could do that in a few different ways. One, obviously, avoiding systemic hypotension. The other would be, I know Dr. Yeaman talked a little about vasoactive medications and that there's usually a difference in preferentiation of which vasopressor to use, but I would specifically avoid medications causing pulmonary vasoconstriction without promoting ionotropy, so specifically phenylephrine. High doses of vasopressin beyond the doses that are listed here may cause coronary vasoconstriction. And vasopressors may have a counterproductive effect and may increase PVR, so this is where ionotropes come into play. The next would be ionotropic support to augment RV contractility and cardiac output. Of note, similar to as Dr. Yeaman discussed, there are no comparative studies between ionotropes and vasopressors, so it ends up coming a lot to what the institution prefers and surgeon preference. This slide is more for reference for you, but the 2 things that I would highlight is that while all the vasopressors that are listed on the right and on the top, norepinephrine, phenylephrine, vasopressin, they will all increase your SVR and they will all also increase your PVR. The 2 ionotropes, milrinone and dobutamine, are known to decrease your pulmonary vascular resistance. However, at the same time, they will also probably cause hypotension and reduce your systemic vascular resistance. So they need to be used in conjunction, and there needs to be a balance between the 2. In terms of some advanced therapies for pulmonary vasodilation, one would be inhaled pulmonary vasodilators. Of note, they're all off-label. They are not FDA regulated, and they're not FDA labeled to be used for this indication, but they do provide localized pulmonary vasodilatation. And the second in severe situations would be ECMO. Now, this slide is here for your reference. It just talks about the different pharmacological agents. As we go from left to right, the first is endothelin receptor antagonists, so that's the ERAs. all of those are oral agents, not something we use in the acute period, or they're not available in inhaled formulations for us to use in the perioperative period. Nitric oxide signaling enhancers is the one in the middle. We'll talk about that a little bit further, and the pathway is listed out here for you. And on the right, we have prostaglandin analogs. Again, something like epoprostenol that we'll talk about in a moment. So the two that we talked about, I know this is a busy slide, but the middle, we're talking about inhaled nitric oxide, and on the right, we're talking about inhaled epoprostenol. Comparing both of them, very similar agents, different mechanism of action, but they both lead to selective pulmonary vasodilatation. In terms of the half-life, nitric oxide is quicker. It does have a 2 to 6 second half-life, whereas epoprostenol has around less than 6 minutes. The one that I would highlight is really on the bottom. So we have delivery system and hypotension. So the delivery system in nitric oxide, as I'm sure most of you are familiar with, it's a very intricate setup, and it's a closed-loop delivery system. The hypotension is present with nitric oxide, and the incidence is around 14%. Comparing that to epoprostenol, it is available through nebulization. The one thing I would highlight is that the inactive ingredients with epoprostenol can bind to that nebulization mesh, and so it could cause variability in drug delivery and potentially failure. This also causes hypotension. Now, continuing to compare the two agents, nitric oxide does have an additional side effect of methemoglobinemia to be concerned about, and epoprostenol in comparison is a potent inhibitor of platelet aggregation. Cost, I'm sure, is something that's on the top of everyone's mind, and nitric oxide is about 4 or 5 times as costly as epoprostenol. The bottom call out is the potential advantages of epoprostenol over nitric oxide. So we talked about the risk of methemoglobinemia that is no longer present with epoprostenol, fewer monitoring parameters, ease of administration, and specifically cost. I'm sure when you guys talk about epoprostenol, with a raise of hands, how many of you guys use Flolan in your institutions? And how many use Veletri? So mixed. Both of the formulations are relatively similar. The stability is really what's different amongst the two, so that's what's in the call-out box here. Veletri does last 48 hours at room temperature. Now, the one additional call-out that I would want to mention is that Flolan specifically uses an inactive ingredient that it has higher binding potential to the nebulization mesh. So there is risk there between the two products of varied drug delivery. In comparing inhaled versus intravenous agents for acute pulmonary hypertension following cardiac surgery, there's limited data. All is small and varied in different populations, which we'll talk about in a moment. And I just want to call out what the summary is. And the summary is there's statistically significant improvement using inhaled versus intravenous in right ventricular performance. And there is overall increase in MAP and a decrease in PVR, although that has not been found statistically significant. Now this next slide, before I even show it to you, I know it's very busy. The reason I put this slide here is just simply for reference. We're not going to cover this, but the number of studies that have been done comparing inhaled versus intravenous are limited. What you see here on the slide are the actual studies that were done. So if you're looking a little bit deeper and you want to know, I mean, it often comes up. The one that I think is interesting is the one in the middle. It's Wang, and it's looking at inhaled milrinone versus intravenous milrinone. There's very few studies that actually look at something like this. So if you're interested, it's here for your reference for you to dig into a little bit deeper. We'll talk about inhaled milrinone in a moment, but for now we'll continue on our path of nitric oxide versus EPO for acute pulmonary hypertension. So we talked about there's limited data. A lot of it has been extrapolated from transplant and ARDS patients. The summary of results is listed here for you, but there's comparable results regarding systemic and pulmonary vascular effects post-cardiopulmonary bypass. There's no difference in the rate of bleeding, no difference in the rate of systemic hypotension, no differences in mortality or ventilator-free days, and significant cost savings with EPO. I have met a few surgeons who swear by the effect of nitric oxide versus EPO, and while that's true, all the studies that have been published show no difference. Although with that said, there is limited data. So what we're looking at when we're looking at no difference between agents is limited to begin with. Now, this is maybe published just a few months ago, so this is exciting. This was the first study that looked at inhaled, or larger, not the first, but the first larger randomized control trial looking at epoprostenol versus nitric oxide for right ventricular support after major cardiac surgery. It was still single center, so still limited in what we have available. It's looking at IV versus nitric oxide. Both agents were initiated prior to separation from CBP, so they did not wait for treatment. They initiated it for all patients immediately and continued until in the ICU until discontinuation criteria were met. All of these patients were open heart transplants and LVADs, so again, limited population and doesn't quite apply to all patient populations that we may see. But they did have, like I said, one of the largest populations evaluated, so 231 patients in this study. A high-level summary is in the call-out box to the right. So inhaled EPO versus nitric oxide has an equivalent effect on rates of postoperative right ventricular failure, but there were no differences in duration of ventilation, hospital and ICU length of stay, acute kidney injury, or mortality. And they looked at it for both 30, 90 days and up to 1 year. Now, inhaled milrinone is something I mentioned briefly. It's not, by a show of hands, how many of you have either heard of milrinone before or use milrinone in your daily practice? I'm going to call on you since you're since you're sitting in the middle. Can you describe what your practice has been so far?
What our practice has been?
Oh, sorry, both of you. I guess you could go first and followed by him.
Our practice has been, we can use it, with certain surgeons have used it as a first line or as an inotrope, and other surgeons have used it as a second line or in conjunction with patients who have pulmonary hypertension or other right side heart failure.
Perfect. How does that align with what you've seen? Same thing. Is there any preferentiation besides surgeon preference of when you would use this?
It depends on the pulmonologist, it
Uh-huh.
depends on the surgeon, and everybody's in the sandbox.
Okay, all right. Well, I think that aligns with some of our data, and unfortunately, same thing as we talked about before, limited to small studies, and there's very few retrospective control trials and a few observational trials, but unfortunately it is mixed, and I believe that it'll continue to stay mixed until we have a few more studies kind of evaluating its use. Just to preface, it's a phosphodiesterase 3 inhibitor. It increases cyclic AMP, and it has the potential to reduce pulmonary arterial pressure without hypotension. Again, limited to small RCTs and observational trials, growing body of literature coming. The two that I've listed here are really the two biggest trials that were done, one in 2020, a newer one in 2023. And the one in 2023 was exciting because it looks at the combination of inhaled milrinone and inhaled EPO before CBP initiation, so as a preventative measure. And they found positive pulmonary vasodilator as a result. So putting all of this together, we talked a little bit about volume, diuresis, ionotropes, vasopressors, and then the specific pulmonary hypertension targeted therapies. So this chart here is to help you kind of identify when to use which. And so in certain situations, if it's hypovolemia, volume would be the answer. Pulmonary hypertension, I think some of these therapies, there's mixed data of when exactly to initiate, whether you initiate as soon as CBP is completed, as soon as you're separating from CBP or previously, or until you wait to see if you're suspecting pulmonary hypertension to even initiate some of these agents. Now, I know, again, this is a busy slide, but I do like this slide because it helps identify a little bit better of when to conduct some of these. I'm going to direct your attention towards the right, so the two gray boxes, possible ischemia versus no ischemia. I'm going to start with the possible ischemia box. If you're evaluating and you think that there is ischemia involved, promoting RV perfusion is really the key here. And so in order to promote RV perfusion, the medical treatment specifically, vasopressors, optimizing preload, and reducing afterload. If you compare that to the bottom where you're thinking that there is no ischemia involved, the goal is to reduce RV afterload, and that's where these inhaled products really come in, whether it's inhaled nitric oxide, prostacyclin, which is the epoprostenol, and milrinone. And if you're looking to improve RV contractility, intravenous milrinone and vasopressors would also be helpful, but just caution to use them in combination to prevent some of the side effects of reduced systemic vascular resistance. Now, sildenafil is also interesting. One last time, I'm going to ask you, raise of hands, if you predominantly use sildenafil in your practice to wean off of any of these agents. So not commonly used. It is a phosphodiesterase inhibitor. It could be used to facilitate weaning, but again, I would recommend that you use it in rare situations, in situations where weaning is not found, and potentially only patients that have an underlying pulmonary hypertension that hasn't been already diagnosed. It does have an additive favorable effect on PAP and PVR without the hypotension, but there is no clinically significant effects on cardiac index or MAP. Varied doses have been studied, which is why it's hard to recommend this routinely, and there's mixed results for continued use, some with negative outcomes. That is the end of today's discussion. Thank you very much.
Any questions for Abby?
Thank you.
So up next we have, where are we? Oh. Okay, we have speakers Mallory Montalvo, who is the Clinical Quality Nurse Specialist at Mount Sinai Morningside, and Marcelina Victory Stewart, who is the Nurse Manager of the Cardiac Surgery ICU, the Cardiology ICU, and the Cardiac Step Down at Mount Sinai Morningside, and they're going to be discussing communications, SBAR, and outcomes, a nursing perspective.
Good morning, everyone. I'm Mallory Montalvo. What is the importance of communication? Communication is a fundamental component of how information is interpreted and comprehended. It is essential for success and is a key transformational tool. Being able to communicate effectively is crucial for patient safety and improves the patient experience by involving them in their plan of care. By employing and fostering the three components of communication, verbal, listening, and body language, clear, succinct communication promotes interdisciplinary collaboration and teamwork. What are the benefits of using communication tools? Communication tools delivered a standardized information sharing structure among the members of the healthcare team. Effective communication helps reduce and prevent understandings and inaccuracies, and thus stimulates collaboration and teamwork. When engaging with the speaker, it is essential that we stop, look, and listen to the message being delivered. We employ a variety of methods to improve and standardize communication. Today we'll concentrate on SBAR, daily huddles, visual management, and standardized pathways. The first tool we'll discuss is SBAR, Situation, Background, Assessment, and Recommendation. It was introduced by the United States military in the 1940s and later targeted specifically for nuclear submarines, where concise and relevant information was essential for safety. It is a systematic framework for communication that helps teams in a hospital exchange information regarding a patient's condition, as well as any issues that need to be addressed. S stands for situation, where you want to provide a brief description of what's occurring with the patient. Situation states the problem and any associated concerns. B stands for background and includes information that relates to the situation described previously. This will include diagnosis, medical history, medications, allergies, labs, and code status. Assessment describes what you assess about your patient that relates to the situation and can include vital signs, lab values, trending in a wrong direction, and include whether the patient is unstable or appears to be getting worse. Recommendation are the interventions you think will assist the patient or your plan of care. What are some tools we use to communicate information on a unit level and system level? We utilize a daily management board, which is divided into 3 sections. The first third reviews the unit flow, staffing, census, equipment, and supplies. The second portion reviews quality and process improvement. Metrics and different storyboards are discussed and also allow the staff to communicate any quality improvement projects they may have. The third portion communicates system-level information and includes monthly messages from our Chief Nursing Executive and Chief Nursing Officer, practice alerts, and copy and grade. The Daily Management Board is a continuous reference tool and utilized during huddle at shift change with all staff members in attendance.
So, what is the role of SBAR? What role does SBAR play in the CSICU? These are only 2 instances of SBAR reporting tools that we utilize. As you can see, both can be used during shift-to-shift reporting. The difference is when they are best utilized. One is the electronic medical record, SBAR reporting tool. It is used to acquire patient information. Nurses read this prior to the patient's arrival from the OR and for the first time they care for a patient. It is presented in the same manner: situation, background, assessment, and recommendation. Our customized format, which was made by the nursing staff, is the second illustration of SBAR reporting tool. While it contains a lot of the same information as the EMR, it does so in a way that highlights the most important elements that the bedside nurse must communicate, keep track of, and record during their shift. We document recent changes in assessment, current lab values, drips and their rates, and hourly and cumulative measurements of chest tube drainage, urine output. This is not part of the patient's record, but the values are recorded in the EMR. So what is the procedure for utilizing SBAR reporting when patients are transferred from the operating room? Upon transferring patients from the operating room to the intensive care unit, the team convenes within the room to provide assistance in stabilizing the patient. The presence of simultaneous conversations, blaring alarms, and overall noise might create a disruptive environment, making communication challenging and increasing the risk of missing crucial information on the procedure and the patient during the commencement of the SBAR report. The anesthesiology team devised their own SBAR reporting tool, which is documented in the patient's EMR. Once the patient has been admitted to their room and their condition has been stabilized, the anesthesiologist will inquire if all individuals present are prepared to receive report. At this juncture, it is imperative for everyone to stop their activities, focus their attention, look at the anesthesiologist, and listen to report. The situation encompasses the patient's name, the date of birth, height, weight, and the procedure. The background includes the individual's past medical and surgical history. The assessment includes the evaluation of hemodynamics, any occurrences that took place in the operating room, the administration of drugs received during the procedure, pacemaker configurations, as well as the administration of fluids, blood, and blood products. Finally, the recommendations will ultimately determine the patient's goal of care, including whether the patient should be fast-track extubated and which drugs were most helpful and which was not. The utilization of this SBAR format has enhanced the exchange of information and comprehension of the plan throughout the postoperative stages. Effective communication of surgical events is crucial for determining the course of action in our plan of care. Now, Michaela, you beat me to it, but visual management is another method. Dr. Yimmons showed us a small portion, but this is what our glass door looks like. This visual management is another method we employ to improve communication. Mount Sinai Morningside 6 East team utilizes an SBAR format to document the patient's progression on the glass door. This approach facilitates the team's acquisition of patient information. For instance, the situation will involve the procedure. The background may include allergies, medications, and lab results. The assessment will include the total hourly output and cumulative output of the chest tube drainage, plus hourly urinary output, significant lab values, electrolyte replacement, current IV medications, and their rates, and the recommendation, again, to decide whether to fast-track and extubate this patient. So, what slide is this? Sorry. Furthermore, excuse me, I had a brain fart. Furthermore, we employ the practice of standardizing clinical processes as an additional means to improve communication. This procedure aims to eliminate avoidable deviations in clinical management and prioritize the delivery of appropriate care at the appropriate time. The CABG pathway outlines the optimal timing and administration of medications, tasks, and directives that must be carried out in a certain order during the patient's hospital stay. Here we see a picture of the CABG pathway reference tool that outlines the preoperative and postoperative tasks that need to be addressed and/or completed in a specific time frame. It is a standardized pathway used to optimize outcomes and formulate goals of care. The CABG pathway is placed in a binder at each unit and on the mobile computers around the unit to ensure the teams have access to it. This is a very important tool for our newest team members, for it allows them to participate in rounds with confidence and address tasks according to their patient's post-operative day. I like to refer to them as talking points. However, all team members utilize the CABG pathway. The post-op tasks are divided into post-op days, and orders are written based on the patient's progress. For example, rounds on post-op day number 1, there's a team discussion to determine whether or not pulmonary catheters, A-lines, JP drainage with A-straps can be discontinued. Chest tube cumulative outputs are assessed, and the need for the chest tubes is determined. Diuretics, electrolyte replacements is assessed, as well as to determine the need for the urinary catheter. GI prophylaxis, beta blockers, aspirin are ordered once the patient can tolerate oral intake, the vital signs are stable, and lab values are within normal limits. From post-op day number 2 and on, the CABG pathway readdresses the tasks not performed the previous day, reassesses the goals of the patient, and includes discharge planning until the patient is downgraded for transfer to the cardiac step-down unit. Once on the step-down unit, this systematic checklist continues to be reviewed until the goals of care are met and the patient is discharged. So finally, these are the various SBAR tools that provides our team with clear direction and information. It compels us to listen. It is a closed loop of communication that allows for feedback and clarification. It is a detail-oriented and adaptable to each individual's communication style. That's it. Thank you.